So, okay. If you've got Photoshop on there, you need Photoshop there.
Yeah. Beauty mode.
Yeah. Alright. So what you're going to have is gloves. You guys should have these in your kits, J-loops.
Mm-hmm.
Okay. You're going to want your J-loops. And you should have an IV start kit. Okay. And then you should have, anytime you start an IV, you always want to take a couple extra. Brings good juju. Okay. Then, you know, you can take them back and put them in when you get on the first stick. So, 20 gauge, remember I told you is the magic. This is a 20. They're typically pink, not always, so make sure you look, but normal color universal is pink. This checkoff's going to be the same thing. You check your doctor's orders, ID your patient, all that stuff, explain the procedure. These J-loops are sterile when you open them, obviously, like everything else. Time out. This is old. This is supposed to be already on there like that. Pretend I didn't do that. So these are sterile when you open them up. And then this is your IV start kit. And you can open it up however you want. We're not going to fail you. There's no specific way to open these, but you'll see everything that's in there. Alright, so this actually has a stat lock in there. Some facilities have these, some facilities do not. So it's just dependent upon that. What it is it actually goes in the arm and it secures the IV because you know a lot of times they get pulled out and stuff. So if tape doesn't do the trick, you can use the stat locks. So just show you the little stat lock thing in here, like this, and it tells you when you place it on there or whatever. I don't typically use these, but you guys have the option if you want to use the stat locks. Alright, op site. When you guys practice, don't open your op sites because you probably only have one or two of these, and once you open these, they don't work. You can't use them again. It's the Tegaderm, so you won't be able to use that. When I get mine out, I go ahead and date it and everything on here because you're going to actually write on this part of it. So I just go ahead and date it appropriately and initial it so it's already ready. I can stick it on there because it's hard to write on a patient. And obviously, since you also have this one, you can date and time on that and stick it on there as well. And since this one has the stat lock, it doesn't have the tape. So let me get my tape because I don't like this. I don't like stat locks. So time out. Tape. And of course, there's no note. Does anybody have tape in their
There's
kit?
some tape sitting on that table. Is it clear?
You
We
know
got some
plastic-
tape over here.
plastic- is somebody got some?
Yes.
Yeah.
Sorry, is that working with you?
If you guys want to use the stat locks, you can. I'm old school, I guess, on this, so I like the tape. So this is how I rip my tape, and you won't be failed on how you do your tape. This is just my suggestion. What you'll be failed about is if it's not secure. So if you only put like one piece of tape and they move, it comes, you know what I mean? So you need to make sure it's secure. I rip about, I don't know, 2 or 3 inch piece of tape, and then I rip it like this, okay? Make sure if you use your bedside tables that you clean them off before you use them because they have lots of germs on them. And then I typically get just a couple of this size and rip off just in case I need extra tape. And you want to prep all this before you mess with your patient. Alright. Tourniquet. I don't put gloves on when I put the tourniquet on unless there's open wounds or blood already there. You're going to touch patients like that, okay? Hopefully he doesn't have poop on his arm. Now if it's an IV drug user or something like that and you'll draw on a lot of them and they have open wounds or MRSA and stuff, then I put my gloves on because I'm not touching all that. But this guy obviously is. Alright, so everybody know how to tie these tourniquets? They need to be tight. You pull up and then this swoops under like that with a little pigtail so that you can just pull that and it goes. They used to have the Velcro ones and people used to carry those on their stethoscopes and use them, but infection control says no, you can't reuse those. So you can't use those anymore. So that's our tourniquet. Next thing we're gonna do is we're gonna identify here, and we're gonna start which way? Proximal to distal, distal to proximal.
Distal to
Alright, so I'm gonna start looking down here. This is a preference of mine, but I don't use hand veins. Unless it's all I can find and there's nothing else, I don't use it because they typically don't hold up very long. So if you have to do a rapid push or anything like that, they'll blow. On those little old ladies and stuff, they're real fair, and a lot of times they're squiggly, so you can't get just a straight, you know, inch line. So my opinion is I would probably, this one looks pretty good right here. You have some big ones. Typically people have the big ones that run right up through here. But this one's low enough. I'm gonna go ahead and go for this one right here. Everybody see that one? Okay. So I have everything kind of prepped. I'm gonna go ahead and take this tourniquet off. Don't make your patient's arm fall off while you're prepping your stuff. The J-loop thing here, do you guys have these in your kits? Fleshes, okay. What I do with my J-loop, and some nurses wait till the last minute, I don't. I take my J-loop. This is a needleless access on here. You guys see it's supposed to use the blunt, so this obviously won't work for this because it doesn't have the blunt tip on here. But you can go on here, and you want to go ahead and flush your IV and then clamp it, because if you don't clamp it, it's going to leak. Okay? These parts here, you see that I'm not touching in here on this end, those are still sterile. You want them to stay sterile. If at any point this hits the floor, it goes to the trash can. Okay? Then I go ahead and I pull this off, because that's going to be what attaches to the patient. I pull it off, and I just make sure it sits in the little sterile area there. Okay? This remains sterile too, because we're going to use it again, so I typically cap that back and set it there for my use. Okay? Any questions so far?
No.
All right. So I'm going to go ahead and put my tourniquet back on my patient. I know what vein I'm going to use. You can have them squeeze their fist or whatever. I'll put my gloves on real quick. This is not sterile, so I'm just putting my gloves on. You want to try and keep it as sterile as you can. I should do like a rap and a dance when I do this, and we put this on YouTube and use this. Alright, so I have my gloves on. This is ChloraPrep, chlorhexidine, and this is most commonly what you're going to see in your Foley kits, and this because then we don't have to worry about betadine allergies with the patient. Okay? So you're going to pop this out. You have to crack it. You just crack it, and then you see as you push down, it fills up the sponge. Okay? And this is going to be the same concept for shots, so you're going to start from the cleanest to the dirtiest where you're cleaning it. Okay? And then you want to let it dry, because it needs time to dry and kill all the bacteria. Alright, now this is I normally wouldn't take this long with the tourniquet on the patient, but since I'm telling you guys. So this is going to be your complete kit here. You pull straight off. And if you guys look along here, you see this little lever right here. That's going to be where you do the push and pull motion when you're pushing the cannula in and pulling the needle out. You guys see how this goes? You see that? That's how it goes. Don't do that because you can shear pieces off the cannula. What you want to do that I would recommend is sometimes these things stick, and then you try to advance it and it kind of gets stuck, and then you're like in the patient. So before I do it, I just kind of just push this forward just a tiny bit to make sure it's not stuck. The cannula didn't go past the bevel of the needle, so it won't shear pieces off. It's just making sure that it's not stuck together. Okay? So don't ever, I had students do this. You do that, throw it in the trash, because there's potential for damage to the cannula. If you break off a piece of that in there, they're going to have a PE and you're going to have a lawsuit. Okay, so don't ever do this. You can just make sure it's a little loose. So I hold it like this. You can do it however you want. You're going to come over here. You're going to pull back. There's an inch there. Does everybody see? There's a straight line that's at least an inch long, because I have to advance my catheter. If you don't have an inch, you're not going to get it in. So I'm going to pull back here. We're going to go in at about a 30, 45 degree angle, right? Because we have to pop the vein. Yes? So I'm going to pop the vein. You guys see my flashback? Now I'm going to drop this down so it's kind of almost parallel. And I'm going to start advancing, and I'm going to start pulling back, all in one motion. You guys see what I'm doing? Did you hear the lock? Okay, so you're going to hear the click. So typically, don't let go of these. or will fail you for letting go of it, but I'm showing you how this is. We know that we're in the vein because there's blood in there. If you don't get blood in there, then you're not in the vein, right? If you get a little flash of blood and then all of a sudden there's nothing, you went through the vein. So when you first see that first flash, as soon as you see the flash, drop it. Pop it and drop it. So once you see it pop, you see the flash, go ahead and drop it and then advance it. Because if you don't drop it after it pops, you're going to go through. Okay? So this is how we're going to go. Did you guys see how that cannula started to crinkle up even when I was doing it? The 22s are really bad. So for checkoffs, save at least one of your pinks for checkoff because they're a little bit sturdier. All right. So now I'm ready to go ahead and do this. Remember I told you your patient's going to bleed everywhere? If you guys get this stuff on your clothes, it doesn't come off very easily. I'll tell you that. So be very careful with it. So the tip of the oh, you know what? Sorry. Gosh, I'm going to blow my vein. Okay. So I got this in, popped it, locked it. I have to get that off. Your checkoff sheet, she went and made copies. You guys can hand this around. You'll see that you have to take the tourniquet off or I'm going to fail you because I would have just gotten failed. You have to take the tourniquet off. If you don't take the tourniquet off, the amount of pressure that's on there when you insert that is going to pop your vein. One thing you can do is when you have little elderly patients, and you keep saying their veins are blowing, what you'll see is when you start to advance the catheter, you'll see a bubble there, and that means it's blown. So you're not going to be able to go. Don't put tourniquets on those elderly patients because what the problem is the vessels are so weak, they can't handle the pressure. So don't apply a tourniquet on them. If you get the young, strapping young men and women that have the veins that pop out, you don't always have to put these on for IVs. Now, if you need blood, you may have to if you're going to have to draw blood. But for IVs, you don't have to put these on. This applies pressure to bring the veins up. Elderly patients cannot always tolerate that because you'll blow all their veins, okay? So, rewind back when I had my tourniquet on and I saw the flash and I went ahead and saw that and advanced it. As I'm advancing that, as soon as I advance it, I'm going to take the tourniquet off, okay? If you don't take the tourniquet off, you're going to lose your vein. Now, I'm going to put my finger right here to hold pressure, so hopefully he won't bleed. We're not going to fail you if they bleed because 99% of the time you're going to get some blood, okay? Especially if they're on Coumadin or Integralin or anything like that. I'm going to put my finger right here to stabilize this, and I'm putting pressure right here. You guys see? And this one, I'm going to go ahead and clip this off, twist it, lefty-loosey, maybe. Okay, it's going to come off. Then I'm going to take this part right here and put it on and twist this on here. Simple. Then you can take your little gauze here and kind of dab that up. If you don't clean up your wet mess, your tape is not going to stick. It'll come off, so you're going to have to clean it up. If you get blood in these, because they're little spiral twists, if you get blood down in there and it bothers you, because it does bother me because the blood is dry in there, if you just take an alcohol swab, alcohol pad, and you can stick the corner in there, it'll wick all of that blood out so it won't dry in there and look nasty. It'll wick it out. This doesn't do that because it's water blood. Make sure you get these things on really, really tight because the last thing you want to do is dress this whole IV with the Opsite, and then in an hour the patient says, my IV is leaking, and it's leaking because this comes detached from that and it's blood coming out and everything else. So after you dry it, I always go back and make sure I tighten it again, okay? Another thing, you notice I've had my hand on this the whole time, one or the other. If you take your hand off this anytime, you'll fail because it's unsecure right now. So you never want to leave it unsecure. This is where my little half piece goes. And what I do is I lift this up. And this is tricky with gloves. I slide it under like that. And just pull it this way. Okay. And then I pull this way and cross that way. Now I can let go because I have something securing it. If you guys want to come look at that, you can. You can see that there's a couple things I don't cover. I don't cover the actual site, and I don't cover the hub. And the reason you don't want to do that is because if this part comes damaged and you have to switch the J-loops out, if it's under the tape, you're going to have to take everything apart. Okay? So I just do it like that. Then I go ahead and take my Opsite. Well, actually, I take this little piece here, and then I do one straight across for double protection. Okay? Make sure my tape's on there. If you have patients who have allergies to latex, Make sure you have the latex-free tape. Sometimes you have to use the paper tape because there's a lot of latex allergies these days, so you want to be cautious of that. If you look on these op sites, one end is completely straight, and you guys see at the bottom how this one's split, okay? The split end usually goes towards the IV part. I don't cover the hub. A lot of nurses will cover the hub. I don't, because if they have to change the tubing out, you're gonna have to undress the whole IV. People say, oh, we have to cover it to keep the bacteria out. I don't do that. It covers it enough. You can cover just the very edge of it, but I cover straight across here. And then I go ahead and mash that down so that it covers around there really well. Okay? And then you guys remember when you put these kind of things on, you kind of have to follow it around. If you don't, it will come up off the patient, and it's like sticky saran wrap. You'll never get it unpuckered, and you'll have to go get a whole new one. So I just follow it around till it comes off. Okay? Then you can take your label off here. Don't ever put the label over the IV site. You want to be able to visualize the IV site all times, because if it goes bad or it gets infected, you want to be able to see it. And if a sticker's over it, you can't see it. So I typically take this IV site and I try to put it on the side right here so that you can see it, but it's not covering your side at all. Okay? And you can put another piece of tape over that if you want. Some people will take an extra piece of tape and cover it because it's kind of like that plastic stuff, and it just kind of reinforces that. Then what I do with this J-loop is, obviously we don't want it to be obstructed. So I just flip that up like that and do like this, because now I can still use the J-loop. It's not occluding it, right? So my next thing, I've got it secured. I'm gonna go ahead and flush it one more time. I'm not gonna take this off now. You guys need to have the appropriate one. We don't have them here. But then I would go ahead and I would attach this on here, and I would unclamp my IV, and then I would go ahead and flush this the rest of the way in. I guess I can go ahead and take this off. See how it's coming out? Because I didn't flush it. And I'll just do like that and then flush it. And I usually pull back just a little, see if I have blood. You see the blood? So we know that we're in the vein. And then I go ahead and flush it. And then you're gonna wanna clamp it before you remove this. If you don't, then the vacuum will pull the blood back out, and then you'll have blood in here again.
Patients hate that.
Yeah, and this is always sterile. I should have put it there, but you shouldn't have to take it off. You should have the appropriate needle, or the needleless system, because the needleless ones have the blunt tips and they just go right in there. So the initial time I flush this, it's clean. It was in here. I can go ahead and do this. Any additional times that you access this IV, you'll need to clean it with alcohol before putting anything in there. Then you attach your syringe, then unclamp it, flush it, then clamp it and detach it. So this should be attached, unclamp it, flush it, clamp it, and unattach it. So it should be clamped every time you put this on and take it off. You guys see what I'm saying? If not, it's gonna pull the blood in there, and you don't want blood backing up, because then it can clot off your IV and cause issues. So this is it. Things I would document the location. So I would say this is gonna be his left forearm. So for me, I would say left medial or left lateral right in here, forearm. 20 gauge, attempts times 1, okay? Inserted IV, blood return visualized. That's important, because then that says you visualize blood, so you were in the vein. Everything went in there, cleaned. Patient tolerated well. Flushed well. No redness or swelling noted, because if we flush it and it swells, then it's infiltrated. So, and then date it and time it. So that's about your insertion stuff. Flushed with 5-10 cc's of normal saline, sterile normal saline. And that's pretty much it. And y'all can look at it. Another important thing is that you guys know how to spike the IVs to hook up to this. I don't typically put this in as part of the checkoff, because to spike 19 bags is kind of wasteful. But if you look at these bags, you guys have the kits. You guys see that one of these has like a little hole in it right here. You guys see the little hole on there? That's where we can draw out of it, or we can put additives into it. The other side has a little thing, you just pop it off, and you take the sheath off here, and then you just spike it in there, okay? Before you spike it though, make sure that you've clamped this off, because if you don't, as soon as you spike it, it's gonna go and you're gonna have saline everywhere. So you wanna turn this off, spike it, and then I usually fill it about that much full, and to fill it you just pump it, kind of push it like that, and it'll pull it down. And then I open it up slowly. You guys know the big end, okay? It's closed right now, so if I go to the big end, it opens, little end's closed, okay? So once I get it on there, then I would go ahead and open it up, and you have to prime the tubing. You guys know you always prime tubing before you put it on your patient, okay? The patients will rip their IVs out and throw them and all kinds of stuff because they've watched ER and people have died from air embolus from these. Or I've had patients even do it when they see a little bubble in there, and they'll yank the thing out and say, "That's all bubble. I'm not gonna die from it." You probably wouldn't, if this whole thing didn't get primed, it probably still wouldn't cause an air embolus. It would have to take a significant amount of
Take
air.
a couple of those.
But people watch Grey's Anatomy and ER, and so they have that mindset. So prime your IV tubing, plus if you use a pump. A lot of those pumps are little babies, and anytime you get a little tiny bubble, it's gonna beep, and you're gonna have to go back in there and reset it and work the bubble through. When you set this up and you use your pumps, and do we actually have the pump in here, or did they move the pump?
I think they've moved them.
Okay. That's odd that they've taken the pump.
Can we look next door?
Yeah, maybe, because I'm gonna show them how to use the
Yeah,
pump.
let's see when this is.
Did everybody get one of these sheets?
No, I need one. So once you get this set up, if this is what we were gonna give the patient right here, you would actually take this part that's connected here to this part, and that's what actually connects to the patient here. And then once you connect it, you would tape it down appropriately. I usually do a couple pieces of tape so it's not just hanging off their arm, because then it pulls this. So you would tape it down appropriately, and then we'd start it up. If you do the IV piggybacks that we've talked about, they usually run through and then they connect to the high port up here. If you're gonna do IV piggybacks and you're gonna use a pump, when you connect these to the pump would be located right here. Your port that you're infusing your IV piggybacks in need to be above the pump, not below. It cannot monitor it below. It has to go actually through the pump. So make sure that whatever port you connect it to has to be above the pump. Okay, does that make sense? Because if you put it on the bottom ports, then it won't help, okay? And you guys have had it. So if you guys have time to come here and play and get your stuff out and connect it, and we'll be in here to help you with all that stuff. So now the doctor came and ordered, we're gonna DC this IV. So we're gonna come in here, when you come in to DC the IV, you're gonna wanna have some gauze, and you can have a piece of tape, or you can have a Band-Aid. And what we'll do is we're gonna take the tape off. And please be careful when you take tape off patients, especially, you know, these little patients that have been on prednisone forever and they have paper skin, because you're gonna rip their skin right off. So if you want, sometimes I'll take alcohol pads and I just rub all over the whole thing because that helps kind of lift it. I'll rub on there, and then I just kind of hold the skin as I pull like this so it doesn't pull them. And I hold here, pull this stuff up, and I just kind of hold the skin down as I pull all of this up. Okay.
This is 100 years old.
Oh, yeah,
Or
that
maybe more.
is old.
Oh, there's one right behind
A pump? Oh. Make sure you get all the tape up before you pull this out. It'd be like pulling the Foley out without deflating the balloon, so to speak. If the tape's still taped and you try to pull it, it's gonna hurt. So make sure you get all the tape up. So I've got all the tape up and everything here. I'm gonna get the bottom part here. And again, just kind of hold on to their skin. And some patients freak out because they think it's going to hurt. It's not really going to hurt. And I just kind of hold this here and just pull straight out. And the first thing you're going to look at is to make sure what?
It's intact.
You have a cannula intact. So documentation that you would note is you would say cannula is IV DC'd from left lateral forearm. Cannula is intact. No bleeding noted. Bandage in place. Or however you want to do that. Bandage in place. No bleeding noted. If you don't put a bandage, then don't put that. But the biggest thing is that the cannula is intact, patient tolerated well, no bleeding noted, and that's it for the DC. And then you just get rid of all your stuff. Sharps in the sharps, and everything else goes wherever. Any questions about that? Pretty basic. You guys have your phlebotomy stuff as well? Did they put phlebotomy stuff in there?
I think so.
Okay.
Yeah.
Did you